Thank you for joining our webinar today. Our topic is a multidisciplinary team approach to pediatric patients with brain tumors, moving towards standardized integrative oncology care. Our team is from Columbia University Irving Medical Center within the Division of Pediatric Hematology, Oncology, and Stem Cell Transplant. I am Michelle Bombasi, the program manager of the Integrative Therapies team under the direction of Dr. Elena Ladas. And before our talk, I would like to thank Dr. Elena Ladas for her inspiration and rigorous research, Erin Corsi for her input on the slide deck, and our providers and patient families within our division. Meet the team. So, as we know, integrative medicine is a blossoming field within pediatric oncology. As more patients and families become curious about this approach to care, the demand increases. And research has shown that patients spend 50 to 75% of their time receiving their cancer treatments in clinic, and typically don't have additional time, resources, or energy to seek psychological and complementary care with practitioners specializing in pediatric oncology outside of the institution. These are additional multidisciplinary team members, not on the panel today, but all of mutual importance. So our objectives today are to demonstrate a model of care with input from a multidisciplinary team, recognize various types of brain tumors, conventional treatments, presentation of symptoms, and options for referrals. And in alignment with the SIO Multidisciplinary Oncology Task Force, the article that they published in 2018, where they identified core competencies, we hope to share our knowledge about how we communicate with one another, leading to hopefully improved patient outcomes and a better quality of life for our patients. We will also gain a deeper understanding of the impact our work has and implementation of this model through a case presentation. So, what does a patient's typical day look like in our clinic? They check in, they're triaged, their labs are drawn, they visit with their NP and or oncologist. If patient makes counts, then the chemotherapy is ordered, the RN accesses the patient, and then the patient is seen by the psychosocial team, nutrition, and a member of our integrative therapies team. If the patient doesn't make counts, they only see practitioners within the integrative therapies or psychosocial team. And before hearing from the other experts on our panel, I thought that I would share the most recent statistics that demonstrate that brain tumors are the most common type of solid tumor and leading cause of cancer-related death in children and adolescent population.
Hello, everyone. My name is Dr. Luca Salontai. I'm a pediatric neuro-oncologist here at Columbia University. And I also want to thank you for the opportunity to join us today and be able to present our work. So before we dive into the symptoms of pediatric brain tumors, I just wanted to grab the opportunity to also talk first about what are the normal brain functions of the different parts of the brain. And as you can see, each parts of the brain is labeled with different colors. The frontal lobe in red is responsible for problem solving, emotional traits, reasoning, speaking, and voluntary motor activity. The parietal lobe in yellow is known for distinguishing between right and left, the sensation, part of able to read, and body orientation. The occipital lobe is responsible for vision and color perception. The temporal lobe in blue understands language, responsible for behavior, memory, and hearing. The cerebellum has a main function in balance, coordination, and controlling of voluntary movements, and also fine muscle control. And then the brainstem is the part in gray responsible for breathing, body temperature, digestion, alertness and sleep, and swallowing. And now, understanding what the brain does normally, we can understand the signs and symptoms when we have lesions in these areas. We're gonna start with lesions in the hemispheres. With a frontal lesion, our patients often present with personality changes. They can have non-fluent aphasia. They can have problems with urinary frequency and urgency and incontinence. They can develop seizures, or they can have hemiparesis, or sometimes these lesions can grow quite large and be clinically silent. If the lesion is in the frontoparietal region, the symptoms are hemiparesis, hemisensory loss, or aphasia. When the lesion is in the parietal lobe, they can present with hemisensory loss, non-fluent aphasia, hemineglect, hemiparesis, homonymous hemianopia, or visual neglect, or anosognosia. In the occipital parietal part of the brain, they present with visual seizures, visual agnosias, or homonymous hemianopia. The temporal parietal lesions can present with aphasia, and the temporal lesions with seizures, memory disturbance, superior quadrantanopia, or fluent aphasia. When we look into the brainstem lesions, we know that different structures in the brainstem have different tract going through. So in the medial structures, when the corticospinal tract is involved, they can have contralateral weakness. When the medial lemniscus is involved, they can have contralateral proprioception problems or vibration loss. The medial longitudinal fasciculus is responsible for ipsilateral internuclear ophthalmoplegia. And when some of the cranial nerves, including 3, 4, 6, and 12 are affected, they can have ipsilateral function loss. The lateral structures house the spinocerebellar pathway, so it presents with ipsilateral ataxia, the spinothalamic pathway with contralateral pain or temperature or sensory loss. The sensory nucleus of the 5th cranial nerve will cause ipsilateral pain or temperature sensory loss, and the sympathetic pathway alterations will cause ipsilateral Horner syndrome. The pons has cranial nerves 5, 6, 7, and 8. So they will have ipsilateral function loss with a pontine lesion. And the medulla part of the brainstem has the cranial nerves 9, 10, 11, and 12, and they will present with ipsilateral functional losses of those cranial nerves. When we move on to the cerebellar damage, we can use the mnemonic vanished, and they will result in vertigo, ataxia, nystagmus, intentional tremor, slurred speech, hypotonia, exaggerated broad-based gait, or dysdiadochokinesia. And then we move down to the spine. If there are lesions in the spine, they often present with pain that can be in the neck, back, upper or lower extremities, muscle weakness or numbness of the upper or lower extremity, general loss of sensation, difficulty walking, pain or difficulty with standing, difficulty with urination or change in bowel habits, or spinal deformities. One of the often seen side effects of brain tumors in pediatric patients is hydrocephalus, and you can see an image of that. It means that the ventricles, which are the fluid-filled chambers in the brain, gets enlarged. And the symptoms of those are oftentimes headaches early in the morning. Patients often wake up with headache or often woken up in the middle of the night, comes with vomiting, irritability, sometimes seizures, somnolence, ataxia. In young patients, we see failure to thrive, personality changes in the older ones, or problems with school performance. Young ones can have a high-pitched cry, and it also comes with vertical gaze palsy. The three main treatment modalities in pediatric brain tumors are surgery, radiation, and chemotherapy. And I'm just going to briefly talk about surgery before passing on the presentation to my nurse practitioner. So surgery has many complications, including hemorrhage, stroke, seizure, meningitis, hydrocephalus, postsurgically as well. CSF leak or pseudomeningocele can result in cranial nerve injury. And one of the side effects we see when the tumor is in the posterior fossa is something we call posterior fossa syndrome. And it has four main pillars. One of them is mutism, the other one is ataxia. It can come with behavioral symptoms and emotional lability, making it very challenging for the patient to have a good postoperative recovery.
Hi, thank you, Dr. Slante. My name is Alexandra. I'm one of the nurse practitioners here. I specialize in neuro-oncology. I'm just going to be going over some of the treatments that we give our patients. So not only do brain tumors and other spinal lesions cause our patients to have side effects, but treatment is also not without side effects. So as listed here, these are some of the common chemotherapies that we treat our patients with: methotrexate, temozolomide, lomustine, cyclophosphamide, vinblastine. Vincristine is highlighted here because vincristine is something that causes neuropathic pain for a lot of our patients, which leads us to refer them to integrative therapy for this kind of pain. We also have to give them other medications to treat this kind of pain. Some chemotherapy and common side effects include nausea, vomiting, mouth sores. Loss of appetite is a big issue for some of our children, which is where nutrition comes in. Hair loss, constipation, sometimes diarrhea, fatigue. We also, a lot of our patients are on high-dose steroids, including dexamethasone, which also comes with a lot of side effects for our kiddos. Increased appetite and weight gain, high blood pressure, bruising easily, blurred vision, muscle weakness, osteoporosis, nervousness and restlessness, insomnia. A lot of our patients have trouble sleeping, sudden mood swings, water retention and swelling, high glucose levels, and immunosuppression. Not only do we give chemotherapy, but some of our patients also undergo radiation therapy, often 5 days a week, for about 6 weeks most of the time. This includes focal and craniospinal radiation if necessary. Some side effects of this include somnolence, skin irritation, general fatigue, or swelling. And then their late side effects include endocrine issues and some even secondary malignancies, which we have seen. So we did talk about some radiation and its side effects, but we also, they do have surgery, sometimes partial resections or gross total resections, which causes a lot of anxiety, pain, scarring, leaving these patients with some scar tissue, and they often feel the residual effects of that. Some of them have BP shunts and have complications due to a shunt. Other procedures that we do here in clinic or in the operating room include lumbar punctures. Some of our children have Ommaya shunts where chemo is injected directly into the shunt that's placed as almost like a port, but it's in their head going directly into the CSF. And they also have scans and transfusions quite often.
We not only utilize integrative medicine in the standard of care therapy for our brain tumor patients, but also they are very valuable for our patients who come to us for different clinical studies. One of our main focus here for brain tumors at Columbia University is a drug delivery initiative for brain tumors. The lack of clinical effectiveness from chemotherapy when administered by normal, meaning intravenous or oral routes, may be because too little drug reaches the tumor due to the blood-brain barrier, which you can see a picture of. One of the tumors which can most benefit from disrupting the blood-brain barrier is diffuse intrinsic pontine glioma and thalamic gliomas, which are aggressive forms of a brain tumor predominantly affecting children. And at this point, there's no curative treatment, unfortunately. The surgical removal is not possible because the infiltrated brainstem and thalamus comprises many vital neurological structures. Our goal here is by disrupting the blood-brain barrier, we can effectively deliver drugs into the tumor or close to the tumor and trying to improve outcomes. The main treatment has traditionally been radiotherapy, which increases the overall survival by a few months, but we're still not at the point where we can call this disease curative. One of the studies we're doing here is called convection enhanced delivery. And during this study, the children undergo chronic administration of medication repeatedly through the blood-brain barrier. You can see this image here. We place a pump subcutaneously in the abdomen and then thread up tubing which connects to a cannula which goes directly into the tumor. This is, as you can imagine, not very comfortable and can come with pain, also with inflammation, nausea, headache, temporary worsening of neurological symptoms. So definitely we rely a lot on our integrative therapy team to help. The other study is called focused ultrasound study. We use ultrasound machine and microbubbles to disrupt the blood-brain barrier temporarily. And it allows us to systemically give medications to penetrate the tumor. This procedure takes about 30 minutes, during which 5 minutes the patient need to remain still. And this is where we rely on the techniques the integrative medicine team teaches to our patients through mind-body practices.
Hello, I'm Dr. Jairus Steinberg, and I am the clinical psychologist as part of the team. And today I'm going to talk about the role of pediatric psychology in caring for children with brain tumors and in coordinating care with the rest of the integrated medicine team. So pediatric psychology is the sort of the combination of general child adolescent psychology and health psychology. And it's a specialized field that focuses on working with children with chronic and acute medical conditions, because we know that these conditions can significantly impact their quality of life and day-to-day functioning. And clinical psychologists or pediatric psychologists have a variety of functions within the hospital setting. They manage acute crises, help families with coping, can help with adherence or compliance with medical regimens and medication. They can help with communication between providers and the family. They also collaborate and help families really navigate the medical setting. A group of psychologists came up with standards of psychosocial care for children with oncological conditions. And this is sort of like best practices, pretty hard to implement unless you have a really robust team. But these are principles that guide our care of children here. And the first two are especially relevant to kids with brain tumors. The first is that children and families with cancer should routinely be assessed for their psychosocial health needs. And the second is that children at risk for neuropsychological deficits, such as those with a brain tumor, should be monitored for different needs that they might have. So when thinking about what these kids need and how we could best serve them and collaborate with the rest of the team, those are two of our primary goals. Why should we care about better mental health when it comes to these kids? We know that better mental health is associated with better quality of life. It can improve rates of adherence. It's also associated with lower rates of hospital readmission, shorter hospital stays, and ultimately can lower healthcare costs. It also matters because more and more, as you just heard in the last presentation, new diagnostic and new treatment techniques are being developed. So kids are living longer and surviving their diseases longer. And we know that as they grow into adulthood, they will have emerging needs that a mental health provider could help address. When thinking about these individuals, we think of combination of factors that impact their presentation. So you have the biological, in this case, it might be like where the tumor is physically, as well as how, like what type of treatment they're receiving and how that's affecting their like CNS and the rest of their physical presentation. We have the social circumstances, including the family, the environment that they're in, as well as psychological. So their pre-existing like baseline disposition, what coping skills they had before diagnosis, and how their family generally copes with difficult situations. Specifically, when we're thinking about brain tumors, we're also thinking about the different factors, including when the tumor was diagnosed, where it's located, and then the treatment that it has. And that can help us predict how they're going to, or how they're going to present in terms of like mood and behavior and what sort of like neurocognitive needs that they might have. So in addition to all this, currently we are treating kids in the middle of an unprecedented pandemic, as well as the unprecedented mental health needs that we're seeing. So kids with brain tumors are not immune to COVID-19 and all of the associated impacts that it's had. So more and more we're seeing like significant rates of mental health concerns, including more significant concerns such as suicidality or kids at risk. So it's important when thinking about these kids and working with the rest of the team to have it in the context of what's happening in the greater society. I think it might be frozen.
Can you see this? Are you frozen, Dara? Okay.
I think so, but I can keep going.
Okay.
So different common concerns that a pediatric psychologist might address when working with these kids are generally adjustment is sort of our main like bread and butter, just helping kids adjust to a new diagnosis, understand what that means and how that like plays into the rest of their day-to-day life. We see a lot of mood concerns, depression, anxiety. We generally expect that people will adjust. We know that people and kids especially are extremely resilient. There's actually a model of resilience in pediatric psychology shaped like a triangle, and the bottom level is where the majority of the population is at. So that's like sort of the group that would just need some brief screening and intervention, but won't really require long-term psychological care. And then as you go up, those are sort of the groups that would need more intense psychological care. But other concerns that we might address, especially with the rest of the team, include feeding difficulties, difficulties with sleep, cognitive difficulties, end of life, and general family coping, because we know any medical condition, especially a brain tumor, is not just affecting the kid, it's also affecting the rest of their family. And we also know that as providers, we're not immune to all of the stressors that are associated with treating these kids. So it's always also important just to think about your own self-care when thinking about caring for these kids, as we know that those two are also extremely related to each other.
Thank you. And now we're moving on to our Integrative Therapies program that was established in 1998, and it is now under the direction of Dr. Elena Ladas. Emphasis is on clinical services, education, and research. Education between providers and practitioners, additionally to patient families and learners. Our team consists of research nutritionists, acupuncturist, physical therapist, occupational therapist, and a research coordinator. We treat patients outpatient, along chairside, inpatient, along bedside, in the ED, radiation oncology, PICU, survivorship clinic, and the Adult Infusion Center, where we expanded in 2014. All of our services are available to patients free of charge. Our program is run through philanthropy, so we're a unique model, and we're able to really see many, many patients due to this privilege. And the services provided are acupuncture, acupressure, aromatherapy, exercise and movement, massage therapy, mind-body medicine, and nutritional counseling.
Hi, everyone. My name is Michelle. I'm a clinical dietitian in the outpatient pediatric oncology clinic, and I'm also the program manager for our international nutrition program called the International Initiative for Pediatrics and Nutrition. So what is the role of the dietitian within this team? So first, we assess nutritional status, and this can come from an assessment of diet quality or calorie or nutrient intake through a 24-hour recall or food record. We assess labs, medications, weight, height, BMI, arm circumference. And together we have an assessment of whether they're low or high nutritional risk, if they're malnourished, which can mean they're either undernourished or underweight, or overnourished, such as being classified as overweight or obese, whether they're falling off their growth curve or not. And then after this assessment, we have a plan. So that could be to help them cope with disease symptoms and side effects of treatment. I know we've mentioned a lot of these already, but we could have dysphagia, increased or decreased appetite, taste changes, sensitivity to smells, mucositis, diarrhea or constipation, and nausea or vomiting, which can lead to food aversions. So a lot of these would be something that I would work with the patient on, but also something I would work with the team on. So for example, Dr. Steinberg, we've worked together on food aversions. Integrative therapy clinicians are amazing at managing nausea. So along with that, we might determine that they're undernourished or underweight or losing weight. And then we might recommend enteral or parenteral nutrition to help them meet their calorie needs. So they might need to be fed through a feeding tube or through a central line. We could also determine that they're classified as overweight or obese, and that would require dietary intervention that I'll go into a little bit more later. And then secondly, after treatment's done, for survivors, we do see a lot of late effects such as obesity, metabolic syndrome, cardiovascular disease that we help manage as well. So I thought it would be nice to go into a few things that are really essential for the dietitian to be involved in the care of the patient for. So the first would be dysphagia or swallowing impairment. This research suggests that this happens in anywhere from 30 to 65% of children with brain tumors. And this can lead to anorexia if not managed well, or could lead to aspiration pneumonia. And in terms of management, this is something that will definitely refer to a speech and language pathologist to assess the safety of their diet and where they're at in terms of swallowing. And that might require a change in dietary consistency. So they might have to thicken their liquids if they're going to drink. They might have to soften or puree their foods or cut them up really small. And there's different levels of that depending on their degree of swallowing impairment. And in some very severe cases, they might not be cleared to drink or eat anything at all. And then sometimes they might need nutrition support. So for example, in those severe cases, they might need to be fed exclusively through a feeding tube via enteral nutrition. Now, the other thing that's really important is that for undernutrition or kids who are classified as underweight, that we're involved in that care as well. So we see that up to, from the research, 31% of children with medulloblastoma and other aggressive tumors are at risk of undernutrition at diagnosis. And up to 94% of patients with medulloblastoma or 39% of patients with other central nervous system tumors can develop undernutrition during treatment. And if they're malnourished or underweight, they can have increased risk of infections, reduced quality of life, reduced tolerance to therapy, can lead to lower cognitive function and stunted growth down the line too. So in terms of management, we always try to go through oral intake first. So can we increase their calorie intake? Can we implement some high calorie or protein smoothies or supplements? And if that doesn't work, they might need, again, a feeding tube for enteral nutrition or parenteral nutrition. And then in terms of overweight or obesity, we can see this from different things, as was previously mentioned. So corticosteroid treatment, it might be due to hypothalamic damage with radiation, surgery, or the tumor itself. For example, we see this a lot in craniopharyngioma patients. Can also be related to some decreased physical activity or dietary changes during treatment, but the reality is it's probably a combination of many of those things in the most part. And during treatment, obesity does have implications. So we know it has dosing implications. And though we've not seen this in the research for brain tumor patients, we do know for other pediatric malignancies that obesity during treatment increases your risk of treatment-related toxicities. Now, we also see a lot of, we see an issue with obesity during survivorship too. So 55% of craniopharyngioma survivors become obese after treatment, but it's not just this particular brain tumor. We do see a higher prevalence of overweight and obesity in other childhood brain tumor survivors as well, even excluding pituitary and craniopharyngiomas compared to the general population. And we know that childhood obesity has a number of effects, such as hypertension, could lead to diabetes, anxiety, lower self-reported self-esteem and quality of life, and then chronic diseases in adulthood, such as cardiovascular disease and metabolic disease. And in terms of management, this is something, again, that, while a dietitian is extremely important, a multidisciplinary intervention is best. So we need to implement exercise, and that might require a referral to physical therapy or integrative therapy clinicians for some movement, and also a behavioral approach. So Dr. Steinberg I would try to get Dr. Steinberg involved as well. However, I will say that it can be very challenging to manage depending on the etiology of obesity or weight gain.
My name is Kenna Bouvet. I'm a licensed acupuncturist and an integrative therapies clinician. So these are some of the complementary integrative health therapies that we most commonly utilize for our brain tumor patients. So we have acupuncture, acupressure, aromatherapy, exercise and movement therapy, as well as other host of additional modalities that we sometimes utilize depending on the integrative therapy clinician. Usually we use a mix of a couple different modalities within one treatment or within one patient treatment. And as I'll continue to discuss, many of these modalities take on a new form in the clinic setting. So here is a list of what we most commonly treat. And as we've all discussed, there's no one way of getting these symptoms out of children. So I might learn of what's going on from the dietitian or the psychologist or vice versa. And as we saw in the slides previous, many of these symptoms come from side effects of the chemo. So we work to not only mitigate at the time of the symptom, but most importantly to prevent. And this is why it's so wonderful to work with the kids, the patients anytime, regardless of how they're feeling. So even if they're feeling great, it's still wonderful to work with them so that we can really prevent what we know is to come in their treatment. So as an acupuncturist, there are different ways we assess the brain and different ways we can look at the brain. We can look at what supports the brain on a physiological standpoint. We can also look at the zang fu, or the organs that help to make the brain healthy in a Chinese medicine perspective. We also look at what the brain represents in Chinese medicine. So marrow is very important, as the brain is the sea of marrow. And then it is also important to look at the trajectory of the meridians, especially when treating these kids in a clinic setting. We might not always be able to use the modality or the acupuncture point that we want to, and we especially can't always do local points. So knowing the trajectory of these meridians can help us effectively treat maybe from a distal standpoint. So here's just a great picture of sort of the brain as we know it on the inside, and then the Chinese medicine trajectory of the meridians going around and into the brain. And so we always try to keep these in mind as we develop treatment strategies and work to look at how we can prevent symptoms from arising. So this is kind of bringing it all together. It's an overview of how we successfully bring integrative therapies to a clinic setting. I would say number one thing is being flexible and understanding the flow and timing of clinic. So sometimes I have time to do tongue and pulse, gather information from the referral source, and even do maybe a quick 10 questions with the patient or the family. But sometimes the most important thing is just mitigating the very acute symptom that's taking place. And then, most often I would say I'm assessing visually as I chat with the family as they're doing paperwork. And then right away, I try to start getting my hands doing some Tui Na or acupressure. It's all sort of happening at one time. And often diagnosis may come later, or even during treatment, or even during the charting that comes after. And then the picture you'll see of the little flat needle up at the top, that is a Pyronex needle. So these have really allowed us to adapt treatment appropriately in the clinic setting. It is a sarin needle that's encased in a sticker. They come in different gauges and different lengths. And because it sticks onto the surface of the skin, there's a lot less concern for them flying out, and there's a lot more ability for movement to happen. So with young kids, A lot of the time I'm on the floor, or I'm playing, or I'm coloring while I'm doing treatment. And even for the older kids, it allows them to sort of be okay with having needles maybe in their hands when they still want to look at their phone. Or, as we know in a clinic setting, the doctor might come in to have a chat, the nurse might come in to access their port, and this just allows the treatment to continue during these other things that are really important, have to happen. This flexibility is key in clinic and has allowed for more acupuncture to take place.
Okay, and now I'm just going to speak briefly about Can Warriors, a pediatric wellness program that is a collaborative effort between the Integrative Therapies program and Columbia University's doctoral program in physical therapy. We realized that our patients were only receiving referrals for physical therapy or occupational therapy while they were admitted inpatient. So that left a wide range of patients and time span where their deconditioning was happening or weight gain was happening. And so we decided to bring PT and OT in and make it not only a clinical experience, but also an educational opportunity. So there are two branches, physical therapy and occupational therapy. And the physical therapy is provided in two different formats, both a group and individual settings. And here are some of the reasons for referrals and some of the impairments within the brain tumor population that we look at to determine who to refer to. And this is a pilot study that we conducted initially to see if this model of clinical care and educational care was actually feasible. And the program has been very, very well received by both staff and patient families. And then furthermore, we conducted an additional study to identify occurring impairments and explore patterns in age and diagnostic groups. And what we found out was that the brain tumor population had the highest occurrence of limitations. So therefore, the incentive to continue and promote exercise and wellness in addition to nutrition and psychology is of key importance in both going through the cancer treatment as well as patient outcomes and trying to decrease late effects in survivorship. And now we're going to present through a case presentation how we all work together as a team.
So I'm going to present quickly the case. This is a 10-year-old boy who was diagnosed back in June 2020 with metastatic medulloblastoma. He received radiation therapy and chemotherapy as a treatment modality. The radiation therapy lasted for 6 weeks, and then that was followed by a chemotherapy of a combination of cisplatin, cyclophosphamide, and vincristine. These medications are known to cause malnutrition. Chemotherapy induced nausea and vomiting, weakness, which actually led to discontinue the vincristine medication. So these were the complications during his treatment course. When he presented, he had very extensive spine disease. Because we couldn't achieve gross total resection in the brain, we decided not to perform any brain surgery, but we only obtained the biopsy from the spinal lesion. This was followed by radiation. However, because of the impaired wound healing secondary to the RT followed by the biopsy, at the site of the biopsy, he developed infection and an abscess. which he required treatment in the PICU, the Brement, and had a lot of pain.
So in terms of the nutritional management for this patient, I thought this case was actually really interesting because you see two sides of the nutrition spectrum. So initially, this patient actually gained nearly 4.6 kilograms or about 10 pounds, and this was related to being on steroids. And since his radiation, he was also reporting some sensitivity to smells as well, which was manageable at first. But then once he started his chemotherapy, he also had some pretty significant nausea and vomiting and abdominal pain. Ultimately, his ability to take food and fluids really declined to the point where his weight actually, not only did he lose the weight that he gained with the steroids, but he dropped a little bit below his pre-diagnosis weight. So we decided to place a feeding tube. So we placed a nasogastric tube, which is essentially a tube that goes from the nose and into the stomach. Because he was not eating or drinking enough to meet his needs, we initiated a formula to provide 100% of his nutrient needs. We accomplished this through overnight feeds. So we've fed him through the feeding tube when he was sleeping. And we also had a few hours of daytime feeds, but I generally try to avoid as much daytime feeds as possible because I want to allow for the opportunity for the child to eat and drink during the day as they want to. So for him, we actually trialed a few different formulas until we found the one that worked best for him. He was not necessarily able to tolerate pretty much any of his formula while he was getting chemotherapy. And he was complaining about abdominal pain even in between his chemotherapy weeks. So we tried a few different formulas to see what worked best for him. We ultimately landed on a real food formula that was peptide based. So it was the proteins were slightly broken down. So it was a little easier for him to digest. And it was a higher calorie concentration. So basically he needed less formula to achieve the same calorie needs. So from January to March, he was pretty much reliant on his nasogastric tube for medications, food, and fluids. But one thing I want to emphasize is that this did allow him to maintain a healthy BMI for age throughout his chemotherapy treatment. So he never became underweight during treatment, which is something we definitely want to prevent. As of March, when he completed his planned treatment, we did start to wean his nasogastric feeds. At this point, he was pretty averse to food and drinking because of all the side effects that he did experience. So it was a very gradual process. We reincorporated foods in his diet, like really one at a time, and gradually increased fluid intake. And it was a very long process for him. And one other thing I'll mention is this patient did have a quite prolonged hospital stay related to COVID right after his planned treatment ended. So that sort of delayed things. Typically, it wouldn't take this long to remove the tube. But finally, in June, we were able to remove his nasogastric tube, and he was taking all of his medications, food, and fluids by mouth.
So I met this patient sort of when he was well he had began his treatment, but I jumped right in, and he was very, very talkative and telling me everything that was happening and all his goals post-treatment when this was all done. He has a wonderful spunk to him. So like everyone has said, I was really called to work with him to work on his nausea. We did a lot of acupressure and acu-seeds for that. Oftentimes I do use aromatherapy, but he, like we said, was a bit adverse to smells and taste. So that was something that really didn't work for him. And I knew that because I was in communication with the rest of the team. And then the other big thing was he was wheelchair bound. So we worked a lot on his leg weakness, his pain, especially the neuropathy that was happening, as well as the abdominal pain. So a lot of Tuena, a lot of acupressure, and then some light stretches that were often done sitting in the chair. It was then one day, I don't know how we got on the topic, but his mom mentioned how he used to love dancing and whipped out the phone and showed me a video of him breakdancing. And I saw the spark in his eyes, and I knew that this was sort of the thing that would really get him to just like continue and have that goal mindset that I saw when I first met him. So we started doing little dances each time I saw him. And the dances definitely, I tried to incorporate stretches and movement. They started in the chair completely, mostly arms and head. But now I'm happy to report that he does these dances standing and even throws in a jump here and there. And he's doing really great.
So I came in and out of treatment, or this patient came in and out of treatment with me sort of at different times of his diagnosis and treatment course. So initially, shortly after diagnosis, I met with him and his mother to talk about their adjustment to the condition, how they were talking about it with family members, with school, with friends, and help him really just adjust to this and what it meant for his day-to-day life. Over time, he adjusted pretty well, but then when there were different complications or setbacks, such as when he was having issues with caloric intake, that's a time when I partnered with other members of the team in order to help. First, we attempted to get him to be able to take food by mouth when that was clearly not going to be the best course of action given everything going on medically. Then we did work around acceptance of the NG tube and thinking of it as not a failure, not something that he had done wrong, but actually just a tool in order to be able to keep his body as healthy as possible. He then accepted it so well that we actually had to do the opposite towards the end of treatment of having him reintegrate food into his diet and liquids, and really retraining his body and his mind to be able to tolerate these things. So really like step by step until he took off and was able to do everything by mouth. We continue to follow him and monitor him in terms of his school needs, getting him tested in order to get any services he might need in the short term or in the long term with school. But also happy to report he is very adjusted. He's actually gone from a kid who had to learn how to deal with this diagnosis to giving advice to other kids and other families going through it. So definitely shows the resilience that these kids have, and how working with a multidisciplinary team can allow the families and the kids to get there.
Okay, so thank you so much. I want to just tie it all together just to share that the way we communicate weekly is through electronic medical record. All disciplines on the team utilize EMR, and we have weekly neuro-oncology rounds. And at that point, I would like to thank all of my colleagues on this panel for the wonderful work that they do in partnership. And I'd also like to thank SIO for inviting us to provide this webinar. And I think we're ready for Q&A now. Okay, so we have one. Can you return to the chemotherapy side effect slide? Sure. Oops, I'm frozen. Hold on.
And while she's doing that, it looks like there's another question. Kenna.
Yeah, no. While Michelle's getting to that slide, there's a question, what sort of massage offerings do you provide? It's a great question. It definitely depends on the type of integrative clinician and what their licenses are. Michelle does a lot of various massages, which she can talk about. I'm mostly trained in Tui Na, which is a Chinese medical massage. So I utilize that along with sort of an acupressure massage, as well as I do cranial sacral technique as well.
Okay, I'll get to that slide. As a licensed massage therapist, with this population, I utilize 2 different techniques. Mostly AMA therapy, which is the massage of tendinomuscular meridians, and acupressure. Also utilize reflexology, really wonderful technique to access Zong Fu, so organs and the trajectory of the channel. Also incorporate some Swedish techniques for relaxation, and we forgot to mention we also provide treatments for family members. So, you know, this is such a stressful environment and time for all families. So while the patients are retaining the needles, we might be able to provide a very mini neck and shoulder massage for the parent, or vice versa. While the parent is retaining needles, we can work with the child.
And that's something that's really great too, when maybe the child is a little bit hesitant to receive our services, but the parents are really open to it. Sometimes seeing your mom or dad or parents have these services gets you excited, and treating the whole family is a really special thing we can offer.
I don't see any other questions in the chat or in the Q&A.
All right, if we have no more questions, we'll give the audience a few more minutes to pop those in there. But I want to take this time to thank our speakers for a wonderful presentation, and the attendees for fantastic, few last questions. And just a reminder that this webinar will be, or is being recorded right now, and it will be posted on the SIO YouTube channel. Oh, looks like we got another question.
So the question is, what about coordination of services outside your integrative therapies team? So yes, if you recall, I mentioned there, I had a slide of the additional multidisciplinary team members, social work, neuroradiologist, and communication is done through the electronic medical record, so secure chat or in basket, or during our weekly neuro-oncology rounds.
All right, if we have no more questions, thank you guys again for joining us today, and I hope you have a great rest of your day.
Thanks so much.
Thank you.
Thank you.